Thank you for that introduction. Good morning, everyone. Thank you so much for inviting me to be here this morning. And I have to admit, I'm very excited to be participating in this event for so many reasons. But for one, I'm a huge believer in collaboration as the path to progress. And I'm pleased that public health is part of this consortium and has been since the beginning of the work. I know that Dr. Larry Madoff, who is the Bureau of Infectious Disease and Laboratory Sciences medical director, has carried the public health banner proudly and represented the public health perspective exquisitely since MassCPR first came together. And public health has benefited enormously from its participation in this consortium. When I assumed the role of commissioner of the Massachusetts Department of Public Health more than a year ago, I was hoping for exactly this opportunity to build on the relationships that we have, and thank you all for making that happen. Also, this meeting is of particular interest because of its focus on data and the potential of AI and data modernization. Data are foundational to so much of what we all do. In public health, data are the tools that help us identify, understand, address, and maybe even resolve some of the most intractable problems we wrestle with every day. The Massachusetts Consortium on Pathogen Readiness, MassCPR, embodies a wealth of expertise in disparate fields, disciplines, and institutions that have all gathered and collaborated for more than 4 years. These gatherings seem to have built momentum over time, leveraging the Commonwealth's vibrant research community to learn from and build off of one another and to develop strategies to prepare for and respond to infectious disease threats. I know that the best weapons we have against any potential pathogens are the ideas of those in this collaboration, their innovation, their research, and their will to advance a lofty goal that could save lives. Everyone in this room is curious and driven. Everyone is here to advance knowledge, to solve problems, and to share information for the sake of health. COVID-19 certainly showed us how it truly takes a village to make the kind of meaningful progress required to fight a pandemic, to understand a threat, to circle the wagons around a microscopic enemy. It takes cooperation and creativity across institutions, scientific disciplines, and borders. COVID-19 has amplified and it's accelerated the scope and nature of research collaboration, a shift that I hope will have a lasting effect on the way scientific research is conducted, making it more open, more rapid, and more interdisciplinary. MassCPR and those gathered here today are a shining example of how the power of coordinated efforts across multiple sectors and disciplines can enhance our ability to respond to infectious disease threats. To say I'm only slightly embarrassed to admit that I've been a groupie of sorts of MassCPR since it was born in March 2020. At the time, I was fortunate enough to be a part of the Division of Infectious Diseases at Massachusetts General Hospital. And I heard about this wonderful concept from one of the consortium's founders, a co-faculty member, Bruce Walker. And I was struck by the vision and the way the founders described it in an op-ed piece that was published in the Boston Globe. Quote, "This is not merely a call to duty. This is a historic opportunity to reimagine and revise the way we tackle future outbreaks. No single institution is going to solve this problem. We need a more nimble, better synchronized rapid response system to mobilize diverse expertise to address the current crisis as well as future infectious disease pandemics. And if past is prologue, come they will," end quote. So at the time, I was on the clinical side of the COVID fence. And like everyone in infectious disease in early 2020, I was frantically learning whatever I could about this mysterious viral enemy that was starting its march across the United States. Our team was preparing for what was likely to come through the doors of Mass General. COVID would, in fact, sucker punch Massachusetts just a few days after the inaugural meeting of MassCPR. This was nearly a week after the Biogen conference in Boston, which took place in late February 2020 and ended up being the state's first super spreader event. In early March, the patients started coming. And by mid-March, the MGH had transformed its ambulance bay into a testing center. converted whole floors into COVID units, and nearly doubled its 133 ICU beds, commandeering pediatric, burn, and neurosurgery ICUs, as well as PACU beds that would have normally accommodated elective surgery patients who weren't coming anymore. By late March and throughout April, it was all hands on deck. It was grueling, it was exhausting, and it was heartbreaking. But as an infectious disease clinician, it was also exhilarating because it called upon everything we had learned, every epidemic and pandemic scenario we discussed, everything we had imagined, and everything we could think to do. I attended the meetings of MassCPR during this time, and I was in awe at the fire hose of innovative ideas and plans that emerged from those sessions. It was truly science on steroids. The brilliance and the engagement of all participants was inspiring. And as some of you may know, I left my full-time role at MGH in early 2021 to go work at CDC. I was still doing a bit of clinical work at MGH, and I maintained my faculty appointment. So I did what any normal, curious, infectious disease physician would do in the midst of a pandemic when brilliant people with varied expertise were gathered together to solve a problem. I kept going to the meetings, even though I think I probably wasn't supposed to with my government hat, and I continued to sneak into those MassCPR meetings. I wanted to hear what these extraordinary people were saying and doing, and then compare that to the information and the data that we at CDC were thinking about and what we were doing. I was data sharing in my own way. So now to be invited to speak at a meeting hosted by MassCPR focused on creating a federated data network that links data across hospitals and public health and other partners is truly a dream come true for me. I feel so fortunate to have had incredible experiences open up to me during my career. Sometimes I think the stars must have aligned as I moved along my path, only to decide to take an unexpected fork every now and then. My journey to DPH was not foreseen. In fact, I had never, not once, thought about public health as a career. I knew I wanted to be a doctor from a young age, but I thought that meant I would go to medical school, I'd take care of patients, and that would be my life. I went to Tufts with the intention of becoming a doctor, and that's exactly what I did. I was a triple jumbo staying at Tufts to earn an MD and a PhD. I loved academic medicine. I loved the blending of care, science, and academia. I found myself drawn toward patients who were vulnerable and disenfranchised in some way. I remember the day I decided I wanted to go into infectious diseases and care for people living with HIV. I was a third-year medical student, and I was rotating on the infectious disease unit at Tufts Medical Center, where there were many patients admitted with HIV. I went in to take a history of a patient who had been living with HIV for more than 15 years, and I sat with him. And as I sat with him, he told me his story. It wasn't a particularly unusual story. In fact, it was quite similar to the stories of many people who were diagnosed with HIV in the 1980s and 1990s. But listening to this patient, I became aware of just how much the system was stacked against individuals like him, individuals who were at risk for HIV, people who were marginalized for being who they are, for having a disease that somehow labels and stigmatizes them. I came out of the room and I talked with my attending about the patient and other patients with HIV. And during our conversation, what struck me was the realization that so many structures exist in medicine and in society that make it so challenging to be someone living with HIV. I'm not talking about the virus itself or the daily medications. I'm talking about the stigma, the insurance fights, the housing problems, the challenges of finding healthcare and of gaining access to life-saving medications. I knew then that these folks with HIV were the ones I wanted to care for. I went on to do my residency at Mass General and had a fantastic year as an HIV fellow during my fellowship. I learned so much, and I learned lessons that I never expected to. I thought as an HIV physician, I would be working mostly with gay and bisexual men, but while taking care of those with HIV, I discovered that it was actually the transgender community, mostly transgender women, and particularly Black transgender women, who were at greatest risk for HIV. This is a group that felt dismissed, judged, belittled by traditional medicine, by its practitioners, and by its institutions, including, at the time, the MGH. Too often, they felt so intimidated and so hurt by the system that they didn't get care because it was just too uncomfortable for them. I felt that if we were to have an impact on HIV, I needed to train myself to provide gender affirming care and to welcome patients into the hospital and into the clinic so that they could access prevention and treatment services. I worked with a team to establish the hospital's transgender health program at MGH in 2018, and I served as its inaugural medical director. We created a space within the hospital that was safe and affirming for the transgender and non-binary community. Healthcare, however, for many populations is so much more complex than visiting providers, getting medications, and signing up for insurance. Healthcare is about transportation. If you can't get to an appointment, you don't get your care. It's about housing and food and feeling safe and feeling supported. And COVID was an especially difficult time for some of our transgender patients. Our program filled up quickly, and the work was hard, but it was fulfilling. With COVID came demands on all of us in infectious diseases. I spent a lot of time taking care of COVID patients in the hospital and rounding and teaching and studying, learning about this unknown disease and trying to help figure out what worked for which patients and why. There were ventilators and ECMO and pronine and hydroxychloroquine and remdesivir and inhaled nitric oxide. There was so much being suggested and tried, and there were so few data, and there were far too many deaths. In December of 2020, the chief of infectious diseases at the MGH, Dr. Rochelle Walensky, was tapped by then President-elect Biden to be the next director of the Centers for Disease Control and Prevention. Rochelle began her role in January 2021, and just a few weeks later, I joined her as a senior policy advisor, working on public health emergency response, infectious diseases, and strategic policy initiatives at the agency. I jumped at the chance to not only be in the eye of the storm of the national response during this time of global pandemic, but also to have the opportunity to work with my former chief, my mentor, and my friend. My 2 years at CDC were amazing. That experience broadened my perspective, and it gave me a front row seat to the profound influence that public health initiatives can have, not just on individuals, but on entire populations. Theoretically, I knew that, but at CDC, I saw that power in action. I saw when it worked, and I saw when it didn't. My work at CDC enabled me to visit states and counties and cities and understand local public health in a way I certainly hadn't before. I also gained an even greater appreciation for the power of data. I spent a lot of time scouring medRxiv, trying to figure out what new data were coming out that might inform our decisions that day or that week. It was tricky because the right public health decision was often quite nuanced. To get there, we had to look at what the science was telling us for sure, but we also had to understand what was practical, given the complex world we were in, right? A world divided by politics, a world that at the time was approaching a year of the pandemic, a world that was fatigued with all of the restrictions and the masking and the isolation. And we had to understand the way society was acting and reacting. It was challenging. The pace didn't slow at all for 2 years. Every day, we focused on how to protect people, how to save lives, and how to approach the pandemic. And through it all, the other work of public health had to continue. There was Marburg virus and Ebola virus emerging in other parts of the world. There was Mpox here in Boston, brilliantly identified by my friend and colleague, Dr. Nesli Bazgaz. And there was the day-to-day public health work. My time at CDC made it crystal clear to me that public health was something I wanted to do, but I wanted to do it back home in Massachusetts. And I wanted to focus on work that would improve the health of the communities and the people around me. I've always been moved by an opportunity to do something that could have a tremendous impact on people's lives. So when the position of commissioner of the Massachusetts Department of Public Health came up, it was one of those moments, and I moved. So here I am about a year and 3 months into my tenure as commissioner, and I've drawn upon my experiences as a clinician, a scientist, a teacher, and an advocate, as well as my experience at CDC. I can bring the pieces of my career together to drive meaningful change and help elevate public health to a more prominent position within the broader healthcare ecosystem. Public health needs the push. To most people, healthcare means immediate, tangible outcomes, treating illness, performing surgery, making a diagnosis, one patient at a time. Public health, however, is about prevention and long-term health improvements to populations and communities. The successes are not immediate, and generally, they're not apparent. The benefits of public health programs, like vaccination campaigns, anti-smoking initiatives, substance use disorder programs, are diffuse and they're harder to quantify. There's a lack of understanding about what public health is and why it's important. And there's little recognition for how potential problems are avoided because of public health. Restaurants are inspected to make sure that they're clean and safe. Water supplies are safe for drinking and beaches are safe for swimming because public health regularly tests them. Countless opioid deaths are avoided each day because public health has a helpline that prevents people from using drugs alone, and because public health puts naloxone boxes at subway stations, and because public health provides free fentanyl test strips. I've got great hope that if we lift up public health and showcase it in the right way, we tell its story correctly, we can change its perception. We can bring it more to the fore. We can define it. We need to educate clinicians about public health and what it offers, how to work effectively with public health departments. When I think about the tangible benefits of the collaboration between medicine, research, and public health, one example that comes to mind is one of the public health interventions that we all might just take for granted, the effectiveness of flu shots. The COVID-19 pandemic transformed our understanding of vaccine effectiveness to the benefit of everyone. Before the pandemic, information about flu vaccine effectiveness was significantly delayed. Researchers had to wait until after the flu season was over to gather and analyze data about vaccine performance. It could take us 6 months to figure out how well the vaccine matched the circulating strains and how effectively it prevented hospitalization and death. We didn't have a system to know in real time who received the vaccine. The rapid advances in viral genomics and surveillance techniques spurred on by the COVID-19 pandemic revolutionized our approach to vaccine assessment. Now, scientists can use new technology to predict vaccine effectiveness against new variants much earlier. This breakthrough enables real-time adjustments to public health strategies and better decision-making about vaccine distribution and other protective measures. Our ability to combat seasonal flu today is a direct impact of the fast-track learning that happened because of COVID. When I joined the Department of Public Health, I spent a lot of time in the initial 6 weeks talking with leadership about the strengths and the weaknesses of the department, our plans, our issues, the morale following 3 years of a pandemic and a public health emergency. And from those conversations emerged 5 foundational priorities that provide a guide for all of us about what we are as a department and where we want to go. The first priority is health equity. We have centered equity across everything we do. One of my earliest moves was to create the position of an assistant commissioner for health equity and to elevate that role to the commissioner's office. In addition, the department spent 2 years developing a comprehensive strategic plan to advance racial equity, a roadmap that guides our work and all that we do to address the persistent racial inequities that impact health access, treatment, outcomes, and overall well-being for the people of Massachusetts. specifically those who identify as Black, Indigenous, Hispanic, and Asian Pacific Islander. Our second priority is a focus on strengthening our emergency response and preparedness efforts. And I certainly hope that the COVID pandemic will be the emergency of our lifetime, but inevitably, emergencies will continue to arise, maybe even another pandemic. We learned a lot from COVID. And when Mpox arrived, we were better prepared for it because of the lessons we learned. There's still much more that we can do to improve our response. Beyond viruses, emergencies could involve threats to reproductive care, problems caused by climate change, mass casualties, hurricanes, blizzards. Right now, we're dealing with an emergency situation prompted by the bankruptcy filing of Steward Healthcare and its potential impact. Whatever the situation, we must have a thoughtful, comprehensive, and flexible system by which we can respond immediately to any public health threat. The third priority is to build our public health infrastructure. And this is an area where I see great synergies with this group gathered today. You'll hear much more about this in a few minutes from Chris Sear from the department. We have big ideas about what we want to do at DPH, but we have challenges with our data infrastructure. We have to invest in and build up our data infrastructure. At DPH, I like to say that we are in the 21st century operating with 20th century data and data systems. Data modernization and investments in technologies like AI will be vital to enable a more efficient and collaborative approach to addressing complex health challenges and to laying the foundation for future innovations in public health. The fourth priority is supporting and promoting recovery and resilience for our public health workforce. With the tremendous work that lies ahead, it's important for DPH to have a workforce that's engaged, one that feels valued and trusted, and one with the right people in the right jobs with the right skills. We must invest in our workforce to build the resilience of people who are currently working at DPH. We must tell the story of the rewards of working in this field so we can recruit a strong and diverse workforce for tomorrow. And our fifth priority is deepening our engagement with the public and our collective dedication to service. I want to emphasize that DPH plays a vital role in this state, in all 351 cities and towns and communities from the Cape to Berkshire County. Those who work in the department are public servants. We have an obligation to be responsive to those who seek information, help, advice, and guidance, and our staff needs to be willing and ready to answer the call, collaborate, communicate, and offer support, whether we're talking about WIC services to a new parent, beach quality to a family on vacation, mosquitoes and the risk of triple E or West Nile virus, new or changing infectious diseases, or a complaint about a healthcare facility. We must be ready to help. We've started to mark progress in these priority areas. We released the strategic plan to advance racial equity, as I mentioned earlier. We're training our workforce to improve our preparedness posture. We're investing in our state public health laboratory to make sure we have the tools that are necessary. And I'm very proud of what we've accomplished in the first year that I've served as commissioner, some of the milestones that we've reached. Yet I also need to acknowledge some of the not so good news we have had to share in the past year: worsening rates of severe maternal morbidity, ongoing racial inequities in our response to the opioid epidemic, challenges with getting vaccines into the arms of those most vulnerable. These too are milestones. They've motivated us to dig deeper, to try harder, to be more creative in coming up with solutions that we'll be tracking in the months and years ahead. As many of you likely know, CDC launched its data modernization initiative in 2019 to transform public health data systems and practices across the nation. The goal of this effort is to enhance the collection, analysis, and use of public health data to bring about faster and more effective responses to health threats. The initiative aims to create a unified public health community that can engage smoothly with healthcare, communicate effectively with the public, advance health equity, and protect and promote health. But there are clear challenges to this effort. For example, information remains siloed across disconnected disease systems. Our workforce continues to have outdated skills. There are burdensome data reporting processes for healthcare providers. In addition, public health has traditionally been excluded from the broader healthcare data ecosystem. To overcome these issues, CDC's Data Modernization Initiative focuses on accelerating the adoption of electronic case reporting, connecting public health to health IT systems, expanding core data sources for early threat detection, and prioritizing data to address health disparities. DPH has several data modernization efforts underway as well to enhance public health outcomes. Our Population Health Information Tool, or FIT, provides accessible and user-friendly public health and racial equity data. It allows for analysis and mapping of approximately 30 health data sets across Massachusetts, focusing on actionable strategies to address community health needs. The Public Health Data Warehouse offers a research tool that provides timely, linked, multi-year data for analyzing health priorities and trends. It's focused on providing data that can inform efforts to reduce morbidity and mortality with a specific emphasis on opioid overdoses. DPH is developing a roadmap for equity-centered data strategic planning. This initiative aims to modernize the department's technology and its systems to advance health equity. By focusing on equity-centered data strategies, DPH seeks to ensure that public health data systems are inclusive and capable of addressing disparities in health outcomes. We're in the process of installing an electronic health record that will link our 4 public health hospitals, Department of Public Health and Department of Mental Health clinics, and the State Office for Pharmacy Services. This is an effort that will bring integrated electronic record system to create a true healthcare system in public health, linked to and accessible to all of public health. And in addition, as part of CDC's Advanced Molecular Detection Initiative, DPH, in partnership with institutions and researchers from across New England, leads the New England Pathogen Genomics Center of Excellence. The PGCOE fosters and improves innovation and technical capacity in the use of pathogen genomics, molecular epidemiology, and bioinformatics in public health. The New England Initiative is one of 5 regional centers that identify gaps, needs, and opportunities for pathogen genomics in public health. It pilots and implements genomics technologies and applications. It provides training in pathogen genomics for the public health workforce, and it prepares for and responds to infectious disease threats. My experience at CDC and DPH has highlighted for me the importance of data-driven decision-making and the need for effective communication in public health. During the COVID pandemic, we had to navigate the rapidly evolving landscape of the virus. We had to implement evidence-based strategies and communicate critical information to both the public and healthcare professionals. This experience underscored the necessity of timely and accurate data in shaping public health responses. It also informed us about the subsequent efforts to modernize data collection and reporting systems at CDC and how to share data openly and regularly. By leveraging clinical insights and research experiences, we were able to advocate for comprehensive public health strategies that are both scientifically sound and implementable. Ultimately, this work will enhance the nation's ability to respond to current and future health threats, and it will take the creative thinking and the expertise of many to make that happen. One challenge will be to achieve data harmonization and interoperability. Developing and deploying systems that can actually communicate with one another is a giant first step. This would mean integrating electronic health records, public health databases, and other health information systems to enable real-time data sharing and analysis. Security and privacy of data will need to be a priority, and public health, including DPH, will need technological infrastructure upgrades and a workforce trained in this type of interoperability. One important challenge will be integrating equity-centered data strategies. Data harmonization efforts must be inclusive and they must address health disparities, prioritizing the needs of underserved and marginalized populations. But while the challenges are significant, data modernization is poised to significantly enhance public health services and improve outcomes for Massachusetts residents. The value of sharing, integrating, and analyzing data is worth doing the hard work and taking the complicated steps that are necessary. The list of those who would benefit from data harmonization is long, and it includes pretty much everyone. The most important beneficiaries, the ultimate ones, of course, are patients and the public. But there are some that would benefit in very specific ways. Researchers would benefit through enhanced data collection, integration, and analysis capabilities, using data sets to study trends, outcomes, and effectiveness of interventions. Providers would benefit from smoother information sharing between public health agencies and healthcare providers, which could lead to better coordination in patient care. Public officials and policymakers would benefit from timely, accurate, and comprehensive data to make better informed decisions. The public health workforce would be able to have more effective tools by which to draw connections with providers, to see trends, to do their jobs more effectively, including addressing health disparities and promoting equity. And educational institutions would have access to improved data sharing and analysis capabilities for research and performance measurement. Our healthcare system has traditionally operated in silos, with hospital data and public health data existing in parallel universes, rarely intersecting or informing one another. This lack of connection remains a significant barrier to truly understanding the complex interplay between individual health outcomes and the broader social, economic, and environmental determinants that shape the well-being of our communities. The promise of linking hospital and public health data has the potential of revolutionizing our approach to healthcare delivery, disease prevention, and health equity. And I would love to see the day when hospital and public data are safe and private, yet also seamlessly integrated, unlocking unimaginable insights and driving transformative change in the way we approach population health. Imagine a world in which we can predict disease outcomes before they occur. We can identify vulnerable communities in need of targeted support. We can design interventions tailored to the distinctive needs of each neighborhood, each demographic, each population. Such a level of precision has the potential to redefine the way we approach public health, shifting from reactive crisis management to proactive prevention and health promotion. Maybe it's too good to be true, but even with the challenges we are facing, this is the time to move this idea forward. The stars are aligned, and maybe we here in this room can redefine the boundaries of healthcare and public health. So I want to thank you for inviting me today, and thank you for all the work that you do and for what you're going to give to this conference. Thanks, everyone. I don't know if I'm supposed to take questions. Yes, I am. Okay. I'm seeing a thumbs up. I'm happy to take questions.
Hi, my name is Aaron Abend. I run the autoimmune registry. There are two challenges to data harmonization and data sharing. One is that the EHR is the system of record that each institution is responsible for, so they really want to control it. The second is the data in that database contains lots of patients that are valuable to the institution as well. The only model I've ever heard of that can encounter these challenges is the health data record bank. There's a challenge implementing that as well, but do you have any thoughts on that?
I have many thoughts, but maybe some that aren't appropriate for a large audience like this. I'll start by saying one premise that I've really tried to keep close and have tried to share throughout the Department of Public Health, which is when we talk about data, in particular, when we talk about public health data, we have to remember whose data we're talking about. And we are talking about the public's data. And I would say that some of these hospitals that feel strong ownership over the data are forgetting that those data are public health data. They really do belong to the public and the communities. They belong to the individual patients, not to the corporate entity. And I think we have to start shifting minds here to recognize that there is a broader role for data beyond just what one corporation may do with the data. I recognize much easier said than done, as people feel very strongly about holding on to their data, and it's quite profitable to have a lot of patients in your registry or a lot of patients in your EMR to be able to mine those data for outcomes. Um, I think what we're trying to do here in Massachusetts are to create a federated data network to bring people together to recognize that there is a benefit in bringing, we can do this in a way that maintains privacy, maintains security, allows individual organizations to have some ownership of data, but then can bring them all together in a way that we can then, with a public health lens, understand what's happening to 7 million people in Massachusetts, that the benefit is worth potentially losing some control of the data. We have to show people that. We have to demonstrate for people why there is a benefit here. I think people can see and think back to COVID. I'll give you an example that I think explains why we need all of these things integrated. When I was at CDC, we were desperate for vaccine effectiveness data, absolutely desperate for vaccine effectiveness data. The systems that were set up had public health on one side, which is who administered the vaccine, and healthcare outcomes on the other side. And we had no way of connecting the two. It wasn't until New York State and the state of California figured out how to connect their healthcare data with their public health data that we could have a real-time understanding of vaccine effectiveness. And because of that, we were able to, weeks after a new variant was spreading across the country, know if the vaccine was effective, right? That connection was so powerful. And I think is an example that we need to lift up and to say, when you connect, when you bring all the data together, when you break down the silos, that you can actually have a true public health benefit, and you don't lose any of the proprietary information that you might need within your system. You don't lose the patient privacy that is so important. I think I'm like preaching to the choir here, though, with this answer. That's probably the problem. What we need is a bunch of hospital CEOs sitting in the room to explain to them why this is so important and to give them real world examples of when you bring data together, the benefit that you can have. I don't think I got in too much trouble with that answer.
You're right. You are preaching to the choir, so I'm not going to try to push it in that direction. But actually, I do remember during the epidemic, the most effective data that we had vaccine actually did not come out of California. It came out of Israel.
Very true.
Because they have a healthcare system that fully captures the patient, and the Clarit system that we were collaborating with. In fact, the students who were publishing the papers in Lancet and New England Journal were actually in my lab. But they had architected the whole system to have data. What's your best guess going forward about how we're going to get there? You're right. We have to convince the CEOs, but they have a lot on their mind. On the other hand, I've talked to some individuals who are going to be leaders, who are leaders at NIH. They're going to try to change some of the laws so that some of the data coming in to the healthcare system will be made available to public health. There are also some companies that are closely working with government who want to set up those databases. If you look into your crystal ball, and God forbid we have another pandemic in 5 years, what do you think is the most fruitful path to getting the kind of data that you would need and others in public health?
So I just talked a lot about the carrots that we could use, the way that we can show the benefits. I think you're talking about what are the sticks that we might need to use to get people there. I think this is true at the federal level and this is true at the state level. Public health has very limited data authority. I don't know if this is common knowledge for this group here, but CDC actually has no authority to understand what's happening in hospitals across the country. The only way that CDC was able to get data on hospitalizations was through a temporary rule passed by CMS that was really implemented through CDC. And because of that, we were able to see hospitalizations, but only a specific set of hospitalizations. So we could see COVID-19 admissions, but nothing else. So when RSV became an issue, I guess now almost 2 years ago, right, we had no insight into RSV hospitalizations. The same is really true at the state level. We have some more control through syndromic surveillance and the way that we manage and regulate healthcare here, but we don't have a lot of authority in collecting data. I do think that we are going to have to go through a process, a legislative process, to give public health authorities to collect some data. We have to be very careful because we don't want all data to go to the government. We don't want all data to be in the hands of public health, but we do need to think about what data are really important. I think syndromic surveillance is one of those data sets that could be incredibly important for public health to have the authority to collect from all hospitals at all age groups and the flexibility to add in new definitions and change what syndrome we're looking at so that we know who's coming into emergency rooms and who's getting admitted to hospitals. I think the optimist in me says that we have alignment of the 50 state health officials, the people in my job. Really do. There's a few exceptions. I'm not going to name those states, but most of us agree that we want that authority and we want the ability to collect the data. The pessimist in me says that the only way for this to happen is for the United States Congress to pass a law, and I think that will be incredibly challenging to do. We can't do this through executive action. We can't do this in the regulatory space. We can only do this through statutory change, and that's going to be very, very hard in DC right now. So I think we're much more likely to see individual states move forward, increase their data authorities, and allow for state public health to start collecting data and then hopefully share those data with CDC in a way that actually provides us a good picture of the country.
Thank you. So actually, that's a nice motivation for making Massachusetts perhaps one of those shining examples.
Yes.
Hi, thank you for your presentation. I got a lot out of it today. My name's Marlene, and I am with Persistent Systems. One of the things that I'd like to know what your thoughts are on is what programs are you going to be putting in place as far as the opioid abatement? I know that a lot of the feds have given a lot of the states funding, and I just wanted to get your perspectives on what programs you felt were most relevant as far as being able to focus on such an important issue.
A great question. And we are, be careful how I say this. I think in some ways we're very lucky here in Massachusetts. We have through the Opioid Recovery and Remediation Fund, which is the large settlement that then Attorney General Maura Healey, now Governor Maura Healey, argued and won. We have about $1 billion that's coming into the state over the next 18 years to support opioid use disorder and to avoid opioid overdose deaths. We combine that with a significant amount of funding that comes in to us through the federal government and also through our state appropriation. And I would say we have, I'm going to pat ourselves on the back a little bit and say that here in Massachusetts, we have probably the most comprehensive set of interventions in place and programs in place for opioid use disorder and substance use disorder more broadly. That said, we also have some of the highest rates of opioid overdose deaths that we see in the country. We did see a 10% drop in opioid-related overdose deaths from 2022 to 2023. We saw some progress here. I'll be honest and say that that drop is exclusively because of a drop in white men. We saw increases in pretty much every other demographic in this state. I think what we're doing here, we're going to continue to invest in the programs that we know work. So we have achieved what we think is complete naloxone saturation in this state, no matter where you are, no matter how rural the county, no matter how remote you might be, you have access to naloxone free from the Department of Public Health, and we think that's really important. We are reaching saturation with fentanyl test strips to give people the opportunity to test their drug supply. And we think that's really necessary. We're combining that with data collection that we do all across the state on drug testing. So we can share back with communities directly and tell them of the various drugs that might be in their community, what percentage have fentanyl included, what percentage have xylazine included, what percentage have other drugs that might be included. We're also trying to invest in some pretty innovative things. One thing I referenced in my remarks was that we have a 1-800 number called Safe Spot, which is a phone number that anyone can call anywhere in the state before they use, so that no one has to use alone. And you go into an agreement with the person on the other end of the phone that they'll stay on the phone with you while you use. If there's any concern after use, either an emergency person is called or 911 is called on your behalf, and someone can come in to reverse the overdose and help prevent death. We're going to continue to invest in all of that. We also think that we need to do things differently, and the $1 billion from the Recovery and Remediation Fund gives us the opportunity to invest differently. We're going to invest more in communities of color, in particular in Black communities in Massachusetts, where the rates of opioid overdose deaths are continuing to go up. We also want to think about the social determinants of health and how we can invest in programs that might get to the root cause of some of the substance use disorder. And in particular, I'll call out housing as a space where we're investing a lot of money. This state has really pioneered an effort to house people with substance use disorder. We have low threshold housing all across the state that allows people to have a safe place to live. And what we found is that it's actually incredibly, I'm gonna be careful about using the word cost effective because I don't think we've done that analysis yet, but it is overall, it only costs $30,000 per year per person to house them. And we have an over 97% retention rate in the housing. And we have incredibly high rates of linking people to medications for opioid use disorder, to recovery coaches, to the whole spectrum of recovery that exists. And so we think continued investment in housing, in particular in communities where housing is an enormous issue, so many of our large cities in Massachusetts, but also our rural areas in Massachusetts, that we can have a real impact on the opioid epidemic and really change the curve. So there's a lot that we're doing here. And I think because of what we have done historically, we've been able to bend that curve, and we're seeing the drop in opioid-related overdose deaths, but we have a lot of work to do. We had over 2,200 opioid-related overdose deaths last year. I think we might have time for one more question if I'm looking at the clock right.
Hi, my name is Peter Ho. I'm an emergency physician at the Brigham Women's Hospital. Thank you for your talk and presentation. My question for you is that I did not hear maybe some strategies engaging in EMS. I think for me as an emergency physician, and I know there's all those states have really linkage, where EMS is really the front line. If you want to talk about surveillance, I think North Carolina had predicted flu before it came actually in 1 year and all that. So I think, having potentially a strategy of case report format, I think you mentioned engaging EMS, if you have, think about it, is really valuable in terms of getting all that information as well.
Yeah, I completely agree with you. And I think for those of you who aren't from Massachusetts, we have this really great thing in Massachusetts, we have 351 unique cities and towns, each with their own local boards of health and local municipal governance, which makes it very hard to do things in Massachusetts, EMS being one of the hardest things to manage because every city and town has their own EMS structure. Sometimes it's a private organization, sometimes it's the municipal government, sometimes it's the firefighters. And so rolling out interventions in EMS is very challenging. But as you mentioned, they are the front line. And so we're thinking about the EMS workforce and what they can and should be doing out in communities. How can they help with vaccination as they did during the COVID pandemic? But also how can they do mobile integrated health and understand what's happening in the community and share that back so that we can have those data available, that same syndromic surveillance data that would be happening in the emergency room is actually happening out in the community. And so we want to invest in that. It's a It's one of those hard things that we have to address. It's a very complicated process, but if we don't engage with EMS all across the state, we will have a black hole in our data systems. Great. I think with that, I'm going to say thank you all for inviting me and for letting me be here this morning. Enjoy the rest of the day.